Hello, and thank you all for coming today to this presentation by Dr. Colin Gundling on the aches and pains of aging. We're going to have questions probably throughout, but also at the end. If you would like to ask anything you don't want to ask aloud, you can type it into the chat function and we will get to those questions. And with that, I will hand things off to you, Dr. Gundling.
All right, great. Thanks a lot, everybody, for coming, and thanks to Cory for organizing this and helping this happen. I think so far it's been a pretty enjoyable series and successful series from my perspective. So I hope everyone else has had a similar experience. And the goal of this series all along has been just to kind of share some of my knowledge and experiences with respect to the aging body and how we are best to approach it from an exercise perspective, making sure we're maintaining good balance, understanding the medical model and how best to navigate it when it comes to like musculoskeletal or body orthopedic type of aches and pains. And so today what I wanted to do was talk specifically about two of the biggest areas with respect to aging that we have issues with. And one is the lower back and lower back pain, and two is lower body arthritis. So I could do an entire talk on either one of these and talk for hours if you really wanted me to. I doubt anybody wants me to. So I wanted to approach this today in maybe a slightly different way than we have in the past and make it a little bit more of a discussion, kind of at least give you guys the opportunity to pose questions to me about each area, and then I will kind of address those as we go, and then I'll put those into the kind of handout that we've done in the past, and then we'll have that handout to get out to you guys. So you guys are kind of hopefully going to help create that handout. So what I would ask you to do is use your chat function here and just type in any questions or thoughts that come to mind with respect to lower back pain first and foremost, and we'll move on to the arthritis at the bottom in the second half of this. But with respect to lower back pain, just put in any questions or thoughts or concerns you have about it. And while you're thinking of those questions and thoughts, I will start talking about the lower back specifically, and hopefully we can kind of create a little bit of a discussion around that. So if everyone can see my screen, they can see here what I have basically on this paper, on this Word document, is the anatomy of the lower back. I think it's good to have an understanding of what we're talking about here. And if you see this, the spine from the side view, we could see 1, 2, 3, 4, 5 lumbar vertebrae is what we have. The lumbar spine is the lower back. We have above it the thoracic spine, and below it is the sacral spine, which is really just the sacrum. It's one bone that was fused over years of evolution and whatnot. But in the lumbar spine is the area that we often get some of the most common issues. In fact, of all the reasons to go to your primary care physician, common cold is the first, and lower back pain is the second most common reason to go to your primary care physician. And when you think about the amount of people that are not going to their PCP with lower back pain, instead they may go to their physical therapist, hopefully, orthopedic maybe, or a chiropractor first, that really kind of tells us that this is an issue. Like a lot of people suffer from lower back pain. And if you are an American living in the 21st century, there's pretty much a 98% chance that you will experience lower back pain at some point in your life. And so this is something we need to gain a better understanding of. And one of the reasons that so many people experience it is, I think, because we don't have a great understanding of it and a really good way of managing it medically. So if we zoom in here, we have the bodies of the vertebrae. Between them, we have the discs, the intervertebral discs. So you may have heard of bulging discs or herniated discs or degenerative disc disease. All of those things are pertaining to these discs right here. The vertebral bodies, sometimes they can end up with something called spondylosis, which is basically like a beaking or a degeneration of the disc, because there's a lot of impact and force through that over years and years. So that might be something you could see on MRIs or imaging. And then in the back here, if we flip, so from this angle here, if you can follow my cursor on the left, we're looking at it from the back, so from behind. You can see this is your spinous process, which is the same as over here. And down here is what's called the facet joint. So if we think of, like, you know, how we have joints, our knees are a joint, our elbows are a joint. This is the joint of the spine right here. So these facet joints, you have one on each side matching. And sometimes these can develop some arthritic changes as well, but they have some like cartilage, just like any other joint, that helps things glide, basically. If we look up here, you can see the disc. So this is looking from the top of the intervertebral disc. You have the outside of the disc. Some of the best way to kind of understand the anatomy of a disc is it's like a jelly donut, basically. So you've got the outside, which is the donut, and the inside, which is the jelly. When we're young, there's a lot of jelly when we're young. As we get older, there's less and less jelly and more donut, which means that disc just doesn't have as much fluid in it. So it's not quite as healthy. It's not it doesn't bounce back quite as easily. So that's when they look at an imaging finding and they identify degenerative disc disease, that's what they're identifying, basically, that this disc doesn't have as much fluid in it as a younger disc does. And then whenever they talk about like bulges or herniations of discs, what that means is that this inside fluid section is trying to work its way out through the donut section, and a herniation is actually when it does work its way out through there. So that's kind of generally the anatomy that we're looking at here. This hole here is where the spinal cord goes. So we're looking at the top of a vertebrae now, and it goes, that spinal cord runs right through here. And then these holes down here from the side are where your nerve roots come out to send your nerves to all the different parts of your body. So if you have ever heard like an L4, there's an issue with your L4 nerve root, or if you have a disc herniation pushing on the nerve root of L4, that's basically the disc pushing right in here and pushing back against the nerve root that would be coming out of here. And whenever we talk about a stenosis, like a stenotic spine, the stenosis can be one of two places. Stenosis means narrowing. So that means a narrowing of this hole here, the hole that your spinal cord goes through, which means that there's more potential for that spinal cord to be pushed on and have pressure on it, or a narrowing of these holes here, which are the foramen. So those can get some narrowing too over time. And when they narrow, they can push on those nerve roots, the nerves coming out of the spine. So if you've heard of stenosis, that means a narrowing. Just like if any of you know anyone or have had heart conditions, they talk about stenosis in the heart as well. That's a narrowing of the arteries in the heart. So that's just a general term for narrowing. We have to define it and say it's lumbar spinal stenosis is the type of stenosis that we're talking about here. So that's generally the anatomy that we're working with. And when we talk about the back and talk about the anatomy, I think it's important for us to understand that this general term of lower back pain that we diagnose all kinds of people with is a pretty bad term. I mean, it's pretty broad. It doesn't define anything. And this is one of our issues, or has been one of our issues with management of this, is that we haven't defined it well to begin with. So there's all kinds of different reasons to have lower back pain. And when we look at this whole group of patients as one homogeneous group of people with low back pain, we're really lumping all kinds of different issues into one group. So then we try to study it by, okay, well, let's apply this procedure or medication to see what happens to these people with lower back pain. And the results are terrible because all these people are experiencing different issues. So over the recent years, there's been a push to define it better, and define it better can mean a couple of things when we're talking about the lower back. It can mean defining it based on the anatomy, first of all, is the first thing you would think about. So the issues with the tissues, basically. So when we mean that, we talk about like the disc bulges that we were referring to, or the stenosis that I was referring to. And that seems like a really great idea. And so with our ability to use all this great imaging that we have, like MRIs and CT scans and things, we can get a really good idea of what's going on from an anatomy perspective in each individual spine. So we thought, okay, this is great. This is how we are going to intervene with these backs. We're going to differentiate people based on the issues with their anatomy, try to link that to symptoms, and then treat accordingly by fixing their anatomy. Hence, the spinal surgery is basically what we mean by fixing their anatomy. The problem with that is, if we look at this other page, now this is really messy. Just so you know, I recognize that it's a little bit confusing, but I'll try to talk you through it. So MRI and CT findings of individuals without low back pain. So these people have no low back pain. And you see down here the age at the bottom, and then the y-axis is percent of the asymptomatic population. So the percent of this population that has this finding. So let's just pick one of these things that we've already talked about, disc degeneration. So degenerative disc disease is the blue line right here. And you can see by the time you are, let's see, what is that, about 60, you have about just under a 90% chance of having degenerative disc disease in your spine without any symptoms in your low back, without any lower back pain. If we look at maybe a less common one, but we did talk about it, disc bulge. So that's the purple with the diamond. By the time you are 60, you have a 70% chance. By the time you are about 85, you have an 85% chance. And then if we look at, let's see, anything else? So facet degeneration, that's the joint of the spine, remember, that we talked about, your facet joint. You can see this curve right here. It increases greatly also with age. So all of this to say that just identifying issues on MRIs doesn't show that this person has issues and needs managed. And that's where our success rates with spinal surgeries is generally not so great. And it's partially because of the idea that the spinal surgery fixes the anatomy, and the anatomy might not be the issue. People have lower back pain for all kinds of reasons, and it might not just be an issue with your anatomy. You could have, you strained something very mild that needs some time to heal. You could have other issues, other things in the body contributing. Maybe your thoracic spine, your upper back is contributing in a way. Maybe your hips are too tight in certain ways that are putting extra pressure on your low back. So then the pain shows up in the low back, but the issue is really somewhere else. So that's not a great way to define it. So what we've done then in physical therapy especially is taken the next step to define based upon symptom behavior, which has been pretty successful. So we can look at an individual and assess them in the clinic and say, okay, your back is, you like this position, you don't like the other position, your back or leg becomes irritated with that position. So based on that, we're going to do these exercises with you to help calm down your pain first, and then let's move on from there. Or, these findings lead us to the conclusion that you would benefit from a manipulation to the lumbar spine. So we get in and do that mobilization to the spine, reassess, and then move on. So this gives us a great toolbox to at least start our treatment from. And then Cory asked, as I understand it, core strength is important to prevent back pain. Is that true? And are there particularly effective core strengthening exercises for back pain? So there's another category of patients with back pain that are called like the stabilization category. So these are individuals that would really benefit from from core strength to help manage their low back pain. And that means in those cases, yes, there's some really good ways to, well, in that population that fits those criteria that we would look for, the core strengthening is the best intervention. But that doesn't mean that any of the other interventions like mobilization to the spine or other types of exercises won't help. It just means that that core strength is going to help a lot. And then we can add on some of the other interventions and techniques that we have. So same with the group that would benefit from lumbar mobilization to the back or manipulation. They will benefit most from that, but then core strength is going to be great for them too. Now, a good point about core strength is that we have there. So the most important point to make about core strength is that core doesn't just mean like your ab muscles, like your six-pack ab muscles. It means your whole trunk, right? So, and I actually include like your butt muscles in this, your pelvic floor, which are muscles, and then your diaphragm, which is a muscle as well. So you've got to think it's a whole system of how this core should function and operate. It's not just one muscle group. So if we think, and one of the keys with respect to core strength is core strength can help support the spine, basically. And the way it supports the spine is by creating an increase in intra-abdominal, meaning inside your abdomen, pressure. Because those muscles contract and increase pressure in there, and that pressure pushes out on the spine and helps to really stabilize it and keep it from moving too much. So our ability to increase pressure, if we think of this, our core, our abdomen as a canister, we've got to make sure we're pushing in from all sides. So if we only strengthen the front of our abs, then we're ignoring the back of our abs, which is the back part of that canister, which the back of our core, which is our low back muscles, and the back part of the canister. We would be ignoring the diaphragm, which is the top of the canister, and we would also be ignoring the pelvic floor, which is the bottom of the canister. So when we are strengthening the core, we have to make sure we do that in a fashion that we're taking into account all these different parts of the core. And so that means not just crunches, basically. there are a lot of different exercises that we can do that can really build strength. There's some general exercise routines and techniques out there that lend themselves better to helping strengthen someone's core with respect to low back pain. The one that comes to mind first is Pilates. Pilates is basically an exercise type where you stabilize your core. So you get a nice, strong, and stable core, and then you move your body parts outside of that to challenge your body's ability to maintain that stable core. So that's a nice thing, a nice exercise program as well. Yoga can be used this way too. Yoga tends to be more on the side of stretching. So in someone that is probably more in that category of mobilization, where we would look to help push their joints to make them move more, those individuals may benefit more from yoga because they're kind of getting to the end range and spending some time stretched there as well. So there are differences for sure with respect to these like Pilates and yoga and CrossFit and different exercise forms. And certain people would be better suited for certain types of exercise. So when we're talking about the intervention from a physical therapy perspective, that's kind of the approach we're interested in taking, is not ignoring the anatomy. We've got to respect the anatomy and understand the anatomy, but we also have to understand that there's plenty of people out there that might have the same exact anatomy without any pain in the back. And so why is that? Like, why, how is that possible? And the answer is that these issues in and of themselves, their existence does not equal pain. But can these issues be a contributor to pain? Yeah, I think that we can say that, but they aren't in and of themselves eliciting pain or starting to cause pain on their own. It's this issue So it's degenerative disc degeneration and a facet joint degeneration, along with some tight hip flexors and tight back muscles, or weak core, or just a lack of movement in general. So that's the next point I would try to make here. And this will lead us well into the next discussion on the lower body arthritis, is the importance of movement. So I can't emphasize it enough. Obviously, I'm a physical therapist, so I like movement for sure, but we can't emphasize the importance of movement enough when it comes to the health of your skeletal system in general. So all of our tissues, and I've talked about this in one of the previous talks that we've done here. So if you were a part of that, then you'd be getting it again, but it's important enough that I think you benefit from it twice. So when it comes to our tissues, they respond favorably to load. And basically what that means is when they are loaded, that kicks off a response in your, in your body that will result in those tissues becoming stronger. In the bones, we see this in individuals that have had the diagnosis of osteopenia, which is basically the precursor to osteoporosis. And they are oftentimes recommended to start doing like loaded exercises, body weight exercises. And what that does is it makes your bones respond to become stronger and thicker and more dense, more mineral dense. Our bones do that, our ligaments do that, our muscles do that, our skin does it, which is evident by calluses on the skin. But again, if we talk about calluses, I think it's always a good example because you can see them. If you load slowly over time, you develop a nice callus, right? If you just are slow and build that up. If you do it all at once, say you had like 10 yards of mulch delivered last weekend and you've got to get it done because it's going to rain on Monday, and you just go after it all weekend. And on Monday, you look at your hands and you have blisters all over them. That was too much load all at once and resulted in a blister and an issue. So that can happen in the case of the bone, where slow loading over time creates a denser bone. Too much loading all at once creates a fracture. And so loading is so important for those tissues that are a highly metabolically active tissues, meaning they get a lot of blood flow, they have a lot of turnover. When we talk about our discs, our intervertebral discs right here, there really isn't much blood supply to these discs. So we're not naturally getting blood flowing to them to keep them healthy. The same exact principle, or the same exact thing is true, can be said for your articular cartilage, which is the slidey, gooey stuff that's between all of your joints. I forget the exact number, but like articular cartilage is some like crazy multiplier, more slippery than ice. So it is a super slippery surface. And that's basically what just helps our joints move smoothly. And the only way that the articular cartilage and the intervertebral disc get nutrients is through movement. As we move, it pushes old fluid out and then creates a little bit of a vacuum effect where new fluid comes in. Old fluid out, new fluid in. Old fluid out, new fluid in. Every time that new fluid comes in, more nutrients come into the area, and then it's pushed out. So if we don't move at all, then that old fluid just sits in these structures, and then those structures start to slowly break down over time, which is why
you're going to be having so many knee problems is because you don't go out and walk or do anything.
Right. Yeah. I don't know if that she intentionally. So talking about getting knee problems because you don't go out and walk and things like that. Absolutely. Yeah. That's absolutely true. And so loading is key to help with the health of these structures across the body. And the intervertebral disc and the lumbar spine, and the articular cartilage are key examples of those. Now, something that we'll always notice in a population that, well, and across the population, as people get older, we start to see these degenerative disc changes. And it always happens down at the lowest disc first, which actually isn't pictured here. It's your L5-S1 disc. It's right below L5 here. It always starts there, and it like just kind of slowly works its way up, disc to disc to disc. And the reason is because if you just think about, like, each one of these vertebrae have weight, right? And then your body around them has weight. So the weight of each segment is pushing down on the segment below. So the weight on L1 is much less than the weight on L5, which means that this disc down here is getting the most pressure and weight through it consistently over the course of your life. And yeah, these tissues are pretty resilient and they have a good ability to respond to movement, but they only sometimes can go so far, and eventually they do start to break down, and they break down from lowest on upward from there typically. So there is such thing as too much loading. Much like when we talk about the knee and we talk about people who run, that's always a great topic to bring up with our lower body arthritis. And I run, so maybe I'm a little biased here, but the science kind of tells this story as well. So when we look at individuals who run, those who run some reasonable amount of miles per week, which equates to somewhere around like 10 to 20 miles per week on average, their risk for developing hip or knee arthritis is about 3%. There's like a 3% risk for those individuals. In people that are otherwise sedentary, so not moving much at all, their risk is about 12%. So much higher, 4 times multiplier higher. And why? Because they're not moving. Now, you may think, well, running is such a high impact sport that's not healthy for the joints. And even high impact can be healthy for the joints, but up to a point, because the key, just like our blisters on our, or calluses on our hand, we have to break that tissue down and give it a chance to rebuild and redevelop. And then we challenge it again and it gets stronger, and challenge it again and get stronger. But if we never give it a chance to recover, then it will continue this downward spiral of breaking down. And they found in these individuals that run, somewhere around like 40 plus miles per week, strung together for years and years, their risk for lower body arthritis is about 13%. So it's a little bit higher than the sedentary population, but it's not astronomically higher. So it's kind of like that old saying, is anything in moderation is probably okay. And actually it seems like running is beneficial even in moderation. So that's something to keep in mind with respect. I mean, I don't expect everyone to go out and run after this unless you want to, but it's something to keep in mind with respect to generally what you're doing to manage these issues. And movement is key because it brings new fluid into the area. The other thing that movement does is it helps us strengthen the muscles around the joint. And if we can strengthen muscles around the joint, then we can take load off of the joint surfaces and put more load into the muscle tissue. The intervertebral discs and the cartilage can absorb some compressive force for sure. Like that's something that is certainly in the ability of that tissue. It can kind of squish down and bounce back up. It's elastic. It's got a spring to it. But this tissue that is classically best situated to take compressive or take some of these forces would be your muscle and your tendon tissue. So if we think through this, so say we're talking about your knee here, and you jump down off of a block and you land. That landing compresses the joint of the knee. And then to stop yourself from collapsing to the ground, you have to resist with the muscles around your knee. Think about your quadricep muscle first, which is the big muscle on the front of your thigh. So that will create a force back downwards and absorb that force of you going down to start to push you back up. And that muscle can absorb that force without putting extra stress through that knee. Now, what typically occurs with people, and I see this all the time, is they'll tell me, well, I've got bad knees. Like my knees are bad. It's just kind of how I'm designed, and that's how life's going to go for me. Which, to be honest, in my experience, the knees from when you're born, the anatomy of the knees doesn't vary a ton. There's some variations from individual to individual. Someone that's like bow-legged or knock-kneed, those are some pretty significant differences from one person to the other. The kneecap or the patella can be in different positions, but it's rare that it's rare that knees are the primary driver of knee pain, honestly. Typically the knees, I look at the knees a lot as kind of a monkey in the middle, paying for the sins of the hip and foot, and lack of strength and utilization of those two body parts. And what I see oftentimes in the individuals that come into here are they utilize their quadriceps, so their front of leg muscle, all the time. So primarily utilizing their quadricep, which the action of the quadricep is to straighten your knee out. So if you're sitting at your chair and you kick your knee straight, kick your foot straight out, you're using your quadricep to do that. And we tend to almost exclusively at times use the quadricep for functional activities throughout our day. Getting up out of a chair, you find yourself shifting your weight forward over your knees and then standing up, which means you're trying to get your weight over your knees so you can just use your quadricep to stand yourself up and minimize how much you're using your hip muscles, like your butt muscles, your hamstring, your low back. And that becomes an issue because then this knee takes all the compressive force, all the load goes through that knee when that quadricep is operating. Where if we can get you to use your hip muscles, your hamstring, your butt muscles, your glutes, your calf muscles, your gastrocsoleus complex more, then we can complete that spring. So the spring isn't all coming from the knee, it's coming from the hip joint and the foot and ankle joint, which distributes the same amount of force over different joints. So then that joint isn't as prone to break down as a knee joint would potentially otherwise. So this is where we can't look at these structures in complete isolation. We've got to look at them with respect to what's going on above and below. Same with the hip. I mean, hip arthritis is very, very common too. Knee arthritis is more common, but hip arthritis is a breakdown. Osteoarthritis is defined as a breakdown of the articular cartilage, which is actually not pictured here in a great way. This white is articular cartilage. Then they show your meniscus, which is not necessarily articular cartilage. And then down below the meniscus is more articular cartilage in there. But if there's a breakdown of that tissue, and that can cause some changes in the anatomy of the knee for sure. Like so people can be born, we'll just say bow-legged is the more common. So born bow-legged, or they could develop that position over years of degenerative changes in the knee where this inside, the medial compartment, the inside of the knee breaks down slowly over time, resulting in that bow-legged look to the knee. When they do a total knee arthroscopy, they can correct that positioning, that malalignment of the knee, which is good because it helps the muscles above and below that knee work a little better. So that is when we're talking about the articular cartilage in the knee, there's kind of three joints that can break down: your medial and lateral compartment, and the patellofemoral joint, which is where your kneecap and this long bone here glide on each other. And when we talk about the hip, there's really only one joint. It's your femoral acetabular joint, which is basically, it's a ball and a socket joint that is a little bit more simple, which is why the recovery from a total hip arthroscopy is a little bit smoother than a total knee arthroscopy. But in general, both are pretty successful surgeries if you get to the point where that seems necessary and indicated. So strength is important, and retraining the body to use different muscles and different joints to take the load off of that joint. So we need motion. We need to help the knee move, or the joint that's arthritic move, to get fluid into it. And then we need to further that by taking some load away from that joint and putting it elsewhere in different joints and different muscles and things of that nature. Other ways to take load off of that, which I think we're going to talk more about maybe in the next session, would be bracing. So we can put braces on and things like that to temporarily take a load off of a joint if it's really inflamed and irritated, to let it heal and calm down, and then we can start to kind of load it back slowly over time. Even in someone that has some arthritic changes, that arthritis won't go away, but the arthritis doesn't have to be painful all the time. It's just if it's reactive and irritated, will it be painful in those cases? So, you know, just the diagnosis of arthritis, I think I talked about this last time, isn't a death sentence to your knee. It's really how you handle it from that point moving forward is what can determine it. And, you know, talking about loading the knee, our bodies are designed to, to handle so much force down through our joints. Like if you're
wait a minute. Shoot.
Do you have a question or not? No.
I finally got the program. It started at 2 and I couldn't get it till just now.
Oh, no.
Library called Aches of Aging, and that's why Nicole hasn't heard from the doctor. No, that's why. Oh, that's yours. Okay. Well, he's talking about knees.
Yeah. Knees and hips.
He's talking about the arthritis in the knees and that sort of thing. And he says bracing may be needed and that sort of thing. So anyway, I should be receiving the recording.
Sure, yes, Charlene.
So,
yes, do you have a question at the moment?
So, yeah. Well, maybe you called me on the cell phone.
I think we might have been on background noise there.
Yeah. Okay. And so, yeah, this applies to joints kind of across the body for sure. But when we talk about load, you're kind of genetically predisposed to grow so tall and have so much body mass and things like that. And if you change what that genetic plan kind of was for you, remember, your joints are designed to take on like what you're genetically predisposed to do, right? So if this is, we're making a lot of assumptions here, but follow me on this one. If your genetic plan was to be 6 foot tall, 180 pounds, then your knee will be, reasonably well designed, you would think, to absorb the amount of force that an average 6 foot tall, 180 pound person would put through it. But if you go about drastically changing that through your lifestyle by gaining too much weight, and you end up being 6 foot tall, 300 pounds, then that joint isn't very well designed to absorb that force. And that's something that we need to really think about when it comes to weight gain and weight loss. And we need to try to kind of get to our body's optimal size so that you can control those forces that are going through your joints. Now, you could think, okay, what if I'm what's the difference between being 6 foot tall? I should have been 180 pounds, but I'm 300 pounds, but it's all muscle and not fat. Well, that's a good point, because it's going to be the same amount of force through your joints, but the difference is what the muscles around your joints are doing. So those muscles around your joints are taking a load off of that joint, and we're going through those muscles a little bit more theoretically. Now, it's probably still not great to be 300 pounds, almost 120 pounds extra of strength of muscle on a frame that's designed to not have that much. But that's kind of the considerations that we have when we talk to people about weight loss with respect to these joints, and how important it really can be to help improve the health of those joints. And there's a pretty exponential factor of load through a knee with normal walking. For every pound extra in your body weight, it's an extra 4 pounds through your knee while walking. So every pound you gain is 4 more pounds. So 10 pounds is 80 or is 40 pounds through the knee. And it goes the other way though. Every pound you lose is 4 pounds out of the knee. So that's something that you can really think about with respect to weight loss and weight control in those joints. So move around, don't sit all the time. Not that, the whole sitting is the new smoking is a bit of an overreach, I think, in some ways, but moving is better. So, you can sit for sure, but sit for maybe 45 minutes to an hour at a time, get up and move around, change positions, do something new, sit a little longer. It's something that, sitting is something that we were designed to naturally do. We probably sit, like traditionally, we probably would be squatting a lot more than we do these days, but sitting as being somewhat sedentary is something that is part of the human condition for sure, because we have to rest and digest and recover and all of that. But do it in a way that you are going to be able to get up and move relatively regularly, or try to get yourself moving regularly. And that will be a lot healthier for your joints and tissues in general. And there's some evidence there with better digestion if you're moving around regularly throughout the day, even if it's light activity, than just being seated can cause some increased absorption of fat and sugar and things like that. So that's beyond what we're talking about, but just move. So what questions do people have here about the kind of all these different topics that were covered? And I would also take feedback on the format here being a little bit more loose format of trying to just have this discussion about where what we need to consider with respect to these issues in joints.
And just a reminder for everyone, you can unmute yourself and ask a question if you'd like, but you can also type one into the chat if you prefer that.
Right. Answered all the questions. Oh, we got one. Are there basic core exercises that we should do? Are there any basic core exercises that we should do? So the core exercises, I mean, if I'm going to pick some of my favorites just from an ease of operation and return on investment of time, it would be some like planking type exercises, because you can plank on the front on your elbows, you can plank on the side to work the side of your core. You can even do some planks or bridges on your back that can help with that. The other thing that's important to consider with respect to the core is your ability to utilize your butt muscles and your glutes. So bridges can help with that also. And just remember though, we talk a lot about low back pain and people that maybe even me or someone else that you're listening to may use the term of bracing with respect to your low back, right? So like you brace your back and then you move it. Your back has to be strong and braced to move in a healthy way, which results in people kind of, keeping their back straight and hinging from their hips in order to move. And that's not what we need to do for the back at all, really, honestly. So sometimes these core strengthening programs where they talk about bracing sends you in the wrong direction of being like fearful of bending and moving the back and think I've just got to keep it braced the whole time, and you can barely breathe because of how strong you're contracting your core. I've had patients like this across the board for sure, of all different age brackets, and that's really just not the case. We've got to move our back. Again, let's get back to this intervertebral disc health. If you're moving around like the Terminator, not moving your back at all, then how are these discs getting fluid into them to become healthier? So you've got to move it, and we just have to learn how to move it with a little bit better awareness of how we're using our core. So instead of bracing, I'll use the term engaging. So you're more so engaging your spine, kind of sucking in and using these core muscles, and then moving along with that. So engage that spine and move with it. And bending, I just saw a study, I would pull it up, but I don't know where it is on my computer, about, they did a study on people that were like injured workers, workers with back pain. And these workers, they basically looked at the whole group. So it was an epidemiological study where they kind of just looked at a whole group of people and identified ones that had back pain and a history of back pain, and the ones that didn't. And then they watched their lifting mechanics. They didn't coach them at all and just said, go lift those boxes, right? So as they watched people lift the boxes, they were looking for that classic, like, so if you've ever had back pain or anything, I'm sure you've been taught, you lift with your legs, you pull whatever you're lifting in close to your core, and so that you're not putting extra stress through your back. You don't want to bend from your spine. You want to bend from the hips and legs. And they found that the people that have had a history or current back pain all lifted like that. Whereas the ones that had no history of back pain at all, and they were fine, bent from the spine, they hinged forward, they didn't pull it in. So like they basically, from the classic model of lifting, lifted the wrong way. And sure, you could say that these individuals that had back pain have probably been coached before and they need to lift like that to get through it. But I think that's an oversimplification, because these people were all doing the same job. And this group that was bending forward and quote unquote lifting improperly was asymptomatic and they had no issues. So there's something to be said for just, finding a movement that is and building up someone's tolerance to a movement. Now, if you came to me with recent low back pain and it was really painful, I'm not going to immediately have you start bending it, moving it, and twisting it. We're going to work to calm it down first, but we're going to work to get your back moving through as much range of motion as possible, because we're trying to keep these tissues as healthy as possible. And the way to get these tissues healthy is through movement. And so remember, when you're looking at like a core stabilization or exercise program, we need movement with it. It's not all about stabilizing and bracing like sometimes planks would do, right? We've got to keep it moving and keep it strong. So if you do planks, that's great, but also incorporate some different movements, even rotational movements and things like that into the program. And there's just a whole myriad of things that you can do for core strengthening. And generally, to be honest, they like 10 years ago or so, it was really popular within the physical therapy profession to teach people like some very intricate core stabilization protocols, where we tell you have this muscle in the front of your abs that's called your transverse abdominis, and you have to suck that in and engage it. And then once that's working, you can build on that and build the rest of the core outward. It was a great thought, but when they've done studies of military recruits, where they brought all these military recruits in, and they had one group that they taught this really specific core strengthening protocol to, and another group where they just did crunches, and they followed them throughout their training and identified everybody who ended up with lower back pain, and neither group was significantly different than the other. So they all ended up with the same amount of lower back pain. So that tells us that probably this really intricate awareness strengthening isn't as necessary for the general population. But I think that there is a reasonable argument to present that some of this more specific training could be beneficial to a certain population. within people with low back pain. Maybe those immediate post-operative cases where the musculature has actually been cut through, that would make sense. Even like individuals with like hysterectomies and things where they went anteriorly through the belly to get to things. So it may not even be those people that have lower back surgery. It may be those individuals that have some other types of surgery, abdominal surgeries, that may benefit from more specific core strengthening, or people that have what's called like postpartum, people will have a diastasis recti, which is basically a splitting of your six-pack muscle right down the middle. And those individuals have really good potential to benefit from this specific training, because the muscle that I've just brought up, your transverse abdominis muscle, actually acts like a corset around our belly. So if we can use that to kind of corset things together, then we can bring the separated parts of our rectus abdominis muscle together to help heal a little bit. So this is what happens when you bring up like a, what is that? Like a 7-word question. I talk for like 10 minutes, but hopefully that answered it somewhat. Any other questions? Probably not. Everybody's afraid to ask a question now.
I do have a question, Colin. I had a spinal fusion surgery in March of 2020, beginning of March, between 3 and 4 and 4 and 5. So it was I don't know if you can call it a double spinal fusion. And I, at the same time, had 5 laminectomies in that area. I did well for 6 months, and I was doing aqua jogging in a pool. So I was okay over the summer. And then all of a sudden I got a pain, like an excruciating pain in my side, and I went downhill, and I've been bad for the year, for 1 entire year, and cannot get it fixed. Looking at the operation and an MRI and a CT scan, and everything is just fine. My question is do you have, does a spinal fusion, I'm sorry I had it, by the way. I might have gone for something less severe the first time through, but after spinal fusions, can you usually depend on other things moving that are adjacent, subsequent movement, because that's so tight in that area, with rods and screws and nuts and bolts and whatever? Is that usually the case?
So if I understand your question, you're kind of asking if like the structures above, are you asking if you should be able to get the same movement back after a spinal fusion?
Anything you need to answer to it or can contribute. I'm sort of sorry I had it, because I was warned beforehand by other people that adjacent, like upper L2, L3, between L3 and, other things can move. They start to move that are on the top of where you had the surgery and below it. Mainly could be because of the surgery. And maybe you can't answer that, because I'm not looking to pinpoint, your words to make any surgeon guilty of anything. That's not, I'm not looking for that. I'm just looking for, does that sometimes happen because they've strengthened that area with, maybe screws into the vertebrae and whatnot, that it's weakened or just from the force of the operation could weaken the ones that are up above and below?
Yep. So with that intervention, there's a lot that goes on, right? So they're fusing, meaning I'm just gonna, you probably understand it, but for anyone else that's listening who cares, they fuse. So they fuse the vertebrae. So it's L4, L5, this vertebrae now no longer moves. The facet joint doesn't move, nothing moves there, whether we rotate, twist, flex, bend, anything like that. But we're still probably getting the same amount of overall body movement with a 1-level fusion, maybe even with like the 2-level fusion that you're having. So you're right when you say, where does that motion go? It goes above and below. So oftentimes with spinal fusions, we end up that 15, 20 years down the road, you need another spinal fusion above and below the spot where you had that spinal fusion initially. So you're saying, you're sorry that you got it, and who knows, in your case, how things would have progressed if you didn't get it. There certainly are some good reasons out there to have spinal fusions, but that is something you really have to weigh pretty heavily. If someone's suggesting a spinal fusion just, there's no going back from it. It's like a total knee replacement. There's no going back from that. It's there. It's done. Done deal. So you want to make sure that it is indicated and necessary in your specific case. And you mentioned that pain that has come back, and it's hard to say why that came back. In like a year's time, I wouldn't say that the segment above it has, gotten to the point where it's just degenerated and it's done. I think that it's probably, who knows? It's hard to say without you in front of me, but something that could be worked on would be what I would say, from a conservative point of view. And the most aggressive approach that maybe you would need is some sort of injection in the spine. You may have already had some of those historically.
Just to interrupt, I just had one last Wednesday.
Oh, okay.
and they said that most times when people have spinal fusions, they've seen it over and over again, that what happens is the SI joint gets out of whack.
Sure.
And so mine did on the right. And so what they did is gave me my first injection, but I couldn't have an injection before that because I was so locked. I could not get on my stomach for a year.
Oh boy. Yeah.
At all, because it was so pulled from my back that I could not get my legs, my thighs, my anything to work to get me onto my stomach. So that's how they do this with a, the x-ray, the fluoroscopy, or what do they call that? Fluoroscopy?
Yeah, fluoroscopy. Yep.
Fluoroscopy. Thank you. And so I couldn't roll over. So I dealt with this for one solid year. So now that I could, they gave me an injection and I feel a little bit better, but I don't like the idea of steroids and a concoction of whatever. I don't trust those. Thinking.
Yeah. No, I mean, you're right that the steroid injections are not innocuous for sure. They come with a bag of side effects. One injection, you could argue that it is not a very big deal. But multiple injections can lead to some joint breakdown potentially. So those individuals that are headed, now that we're not talking about the lumbar spine here, but in a knee replacement, like those individuals that are headed towards a knee replacement anyways, you might as well buy some time by injecting it, if you're up for that. But you want to be careful with multiple injections in other scenarios. But yeah, I mean, it sounds to me like you're in a situation where movement, like trying to, you said locked up. So when you're locked up and not moving, there's other things that are, the health of those tissues is decreasing as you stay in those positions. So trying to find ways to move and move in those directions that feel okay. And the directions that don't feel okay, it's all right to avoid them for now, and then maybe get some guidance from a professional at some point to just figure out when you can start to move into those other more challenging positions.
Right. For anybody that needs work with back or knees or anything, I found that one of the particular things that is very helpful for me is Aqua Aerobics.
Mm-hmm. Yeah, and so at Alliance we have a pool too, so we can help people. Say you're just not sure what you should be doing in the water, and you're worried that just going to a general Aqua Aerobics course is going to be maybe too much, or they don't understand it, your specific condition. Then we could set up some aquatic therapy sessions and help you through that too, for sure. So. If you have any other questions, my email is on the chat. It's up at the top. You can shoot me an email. I'll be happy to answer it. And then if, kind of talking about Alliance, the other thing that is important to keep in mind is that you can come to physical therapy without a referral from a physician most oftentimes. So we can kind of make it work for you. We may have to approach your insurance and let them know, but otherwise it's a pretty straightforward process. So reach out, and feel free to reach out so we can kind of help you get moving and get better a little faster, and from a more movement-based perspective than maybe before. That's probably the biggest thing to keep in mind, though.
Did you say, let me iterate, did you say you do not need a referral or a script or for?
Correct. Yep. You don't. So we have our direct access license now in Pennsylvania. So we can see people without a referral. We can initiate care without a referral, unless it's like a workers' comp or auto insurance. Those are the only two cases where we can't.
Okay. Once again, Colin, very helpful.
Yes,
Thank you
very much.
Thanks for listening.
Yeah, and so this should be posted online this week on our Facebook page and probably on YouTube as well. If you have any questions, I included my email address down there as well. And yeah, just thank you everyone for coming, and thank you for another excellent presentation, Colin.
Thank you.
So would we be able to see the whole entire recording again?
Yeah, it should be. Once I get the chance to transfer it, it should I should be able to post it all in one block to YouTube. So
Okay, perfect.
all right.
Thank you.
Thank you guys for coming. Thank you, Colin, and everybody have a great day.
Yep, you too. Thank you. Bye now.